Hi, I'm Julian Halcox. I'm Professor of Cardiology at Swansea University Medical School. I'm a consultant cardiologist in the local Swansea Bay University Health Board, and I'm a consultant cardiologist here at Sancta Maria. I'm a general cardiologist, so I look after patients with all kinds of cardiovascular disease, but my main focus is atherosclerotic cardiovascular disease and prevention of cardiovascular disease. So managing blood pressure, lipids, and providing a good assessment of patients' cardiovascular risk and a tailored program to diagnose the problems and to manage their risk and their symptoms as effectively as possible. I've been interested in cardiovascular physiology for many years. I was a sportsman as a young man, and I still enjoy keeping fit. So cardiovascular performance is something that's always interested me. As I went through medical school and my general medical training, cardiology really drew me in, as it was a field of medicine where you could really get to the crux of the problem with the wide range of highly accurate, informative tests that we have available to diagnose patients' problems and to stratify their risk, and also the increasing number of interventions that we have that can really move the dial in the way the patient's symptoms are managed, and also preventing the risk of developing problems in the future. So that idea of a really comprehensive assessment of the problem and tools that are available to actually deal with the problems effectively with the evidence base supporting that is really the crux of why I'm a cardiologist. So a typical patient journey involves either a referral from the GP or the patient considering that they have a problem that they want to see me about. The initial consultation will be a more detailed assessment of the symptoms, the risk factors, the problems that they're having and their past medical history, perhaps any medications they're taking. There'll be a physical examination, and then we'll consider some investigation. So simple investigations in the first instance, like electrocardiograms, chest x-rays, maybe an echocardiogram, which is an ultrasound scan of the heart, or heart rhythm monitoring, depending what the problem is. So we try and start a blood test as well. We try and start with a general assessment of the clinical problem, define an investigation plan, ideally non-invasively in the first instance, but in patients who've got more advanced symptoms, we may need to proceed to more detailed management, such as cardiac MRI or invasive testing with cardiac angiogram to see if they need more advanced treatments, such as stenting or surgery, pacemaker implantation, and so forth. So the heart attacks can present in many ways. The most common way of presenting is with chest pain, generally quite severe chest pain, central pressing. And typically when patients have more acute cardiac problems, it's associated with sweating, feeling sick, often with a sense of impending doom. And that's a sign to get in touch with the emergency services and get yourself to hospital quickly, particularly if that pain doesn't settle after 20 minutes, half an hour. It can present in other ways as well. So particularly in older people, patients with diabetes, and more commonly in atypical ways in women than men, perhaps with abdominal discomfort, perhaps just feeling generally unwell or collapsing. However, there's many other explanations for that. So if people suddenly become acutely unwell with pain in the chest or in the chest region, or have alteration or loss of consciousness, that's a serious sign to take things very seriously and seek urgent care. So what's the difference between a heart attack and a cardiac arrest? Well, cardiac arrest is when the circulation breaks down because the heart stops working. So that the heart either goes into ventricular fibrillation, which is where the muscles start quivering and don't provide effective pumping action, or perhaps stop pumping altogether due to loss of electrical activity. So a cardiac arrest is basically where the heart just stops working and is not providing any output to keep the body going. A heart attack, in its sort of euphemistic form, is the words that we use for a myocardial infarction, which can cause cardiac arrest, but often causes non-fatal injury to the heart muscle. And so that the heart attack or myocardial infarction is, for the vast majority of cases, due to a clot forming suddenly in a coronary artery, most often due to the rupture or ulceration of one of these fatty atherosclerotic plaques that breaks open and the circulating blood starts to clot, blocking off the flow of blood to the heart muscle. So a heart attack is damage to the heart, which can cause cardiac arrest and death, but a cardiac arrest is where the heart suddenly stops working. More often than not, that's actually due to a heart attack, but there are other causes of cardiac arrest, such as heart muscle disease and cardiomyopathies and so forth. So many different things that can cause that. So heart disease is a very common problem. We know that the progression of heart disease often starts very, very early on in life, particularly in people with risk factors present at an early age. And with the burgeoning prevalence of obesity and the associated impact on cholesterol levels, insulin resistance, high blood pressure, we're growing plaques in our arteries over the course of our lifetime. And it's often the very first time that people know they've got cardiovascular disease, actually when they present with a heart attack or a stroke, which in almost half of these cases can prove fatal either immediately or within the first few days and weeks. So it's really important to get yourself checked out with your GP or perhaps with a person specializing in preventive care to know what your risk factors are like, and perhaps to evaluate whether you might have symptoms or signs of cardiovascular disease. So it's a very, very common problem. And as often as not, people don't know they have it until they get properly checked out. But certainly if you have symptoms such as chest pain, breathlessness, palpitations, dizzy spells, and so forth, you really should be evaluated by your GP and where appropriate by a specialist. I'm a general and preventive cardiologist, so the type of person who should come to see me is someone who's interested in understanding their risk of cardiovascular disease. For example, if they have a family history of heart attack or stroke, particularly if that relative was presenting at a young age, or if they have symptoms of cardiovascular disease such as shortness of breath, chest pain, dizzy spells, lightheadedness, palpitations. But perhaps why they should come and see me rather than my other expert colleagues at Sancta Maria is that my particular interest is in preventive cardiovascular medicine and also management of high blood pressure and orthostatic hypertension, POTS, and investigating and treating people who may be presenting with coronary artery disease, so chest pain and breathlessness on effort. Why Sancta Maria? Well, I practice in two hospitals, in Singleton Hospital in Swansea with my NHS practice, and Sancta Maria, I do one private clinic a week here. Sancta Maria is the only private clinic in Swansea. I do a very limited, focused private practice because I'm a clinical academic, so I have a very busy working life, both working in the NHS and undertaking cardiovascular research in the medical school. So Sancta Maria is convenient, but in particular, it is a very high quality, friendly, clean, modern hospital where I feel we can offer patients the very best care locally. Cardiovascular disease prevention is very important. Cardiovascular disease prevention really means taking better care of your cardiovascular and metabolic health before it's too late and you actually develop clinical disease and all of the problems that ensue. So cardiovascular prevention involves largely what you do for yourself in terms of maintaining a healthy lifestyle and exercising regularly, eating well, whole foods, avoiding refined and processed foods, drinking modestly and not smoking. But then also monitoring the things that we know can increase the risk of developing cardiovascular disease over the course of a lifetime. So measuring your weight, measuring your lipid profile, particularly your bad cholesterol profile, your non-HDL cholesterol, your triglycerides, measuring your levels of insulin resistance, i.e. whether or not you're diabetic or whether you've got a tendency to diabetes, with some simple metabolic tests such as HbA1c, insulin levels, glucose, and particularly importantly, and something that you can do at home, measuring your blood pressure and how that varies over the course of days and weeks, taking lifestyle measures to address these, and where necessary, where the risk is particularly high, either by high levels of individual risk factors or the way that we consider them together, perhaps to use medications to reduce that risk of developing the disease over the course of the lifetime. We can also arrange for more detailed advanced biomarker testing and also investigation of the coronary arteries with non-invasive imaging with coronary calcium scoring to see if there's already evidence of disease developing in the arteries before it becomes a clinical problem. So reduced effort capacity, so getting out of breath or struggling at levels of exercise that other people can manage without a problem, can be an important sign of heart disease, whether that's heart failure, heart muscle disease, coronary disease. However, it's often just a sign of deconditioning and poor cardiometabolic fitness. So it's important, if you are developing these sort of symptoms of limited effort tolerance, to get that properly evaluated. And that obviously it's different for each individual, but that may involve general clinical assessment, physical examination, looking for signs of heart failure, valve disease, significant hypertension, some laboratory testing, but also some specialist heart tests with electrocardiogram, echocardiography, and perhaps some form of stress testing on a treadmill with some drug testing, or maybe even a CT scan of the coronary arteries, depending on what we're finding during the evaluation. So if you have had an unhealthy lifestyle over time and you're starting to feel limited on effort, it's perhaps a good idea to get your general cardiovascular health assessed with some specialist testing that's guided by a specialist who knows what they're doing. Yeah, so alcohol is an interesting issue. There's a number of studies looking at the relationship between alcohol intake and clinical outcomes, showing what's described as a J-shaped relationship between the amount of alcohol you drink and your outcomes. And so people who drink no alcohol perhaps being at slightly higher risk of developing cardiovascular disease over the course of their lifetime than people who drink maybe 1 or 2 units per day. But then beyond that, the further amount you drink is associated with increased risk. There is some suggestion that is a somewhat spurious relationship, as that some of the people who don't drink alcohol in these studies are people who previously drunk a lot but no longer do, so they'd stored up some of the damage associated with alcohol. In general health, probably any amount of alcohol is a little bit more harmful than not drinking at all. With cardiovascular health, it's probably okay to drink 1 or 2 units per day. Alcohol itself is a poison, but the poison is dose related. The more you drink, the more the risk, and that's manifest by direct toxicity to heart muscle cells, by a tendency to gain weight and reduce your metabolic fitness, to put it simply, and also the more you drink, the bigger the impact on your blood pressure. So higher blood pressure with increased alcohol intake. So it's important, if you want to really take good care of your cardiovascular health, to moderate your alcohol intake. So you're drinking a small amount of alcohol at the most. Chronic intake is bad, but binging is probably worse. Heart disease is so common. There's an important genetic contribution to risk as well, in the way that our body's programmed to regulate the blood pressure and to adapt its metabolism, particularly with regard to the way that it processes fats, cholesterol, and sugar. So there are people who are genetically programmed to have more atherogenic, so processes that drive the development of atherosclerotic heart disease, even with a good, healthy lifestyle. So it's important to be able to keep an eye on your risk factors. Similarly, with diseases, cardiovascular diseases other than atherosclerotic cardiovascular disease, such as developing heart failure or heart rhythm problems, there are very important genetic causes and other environmental causes that you might not know that you're exposed to, various environmental toxins that can increase the risk of developing heart muscle disease or heart rhythm disease. And of course, the biggest risk factor we have of all, however healthy our lifestyle, is just getting older. And we're living in an aging society, which is great. People are living well into old age, but even on the background of a healthy lifestyle, just the wear and tear of being alive for so long in a modern world does increase the likelihood that we're going to develop problems with our arteries and heart muscle and blood vessels to the brain over time. So it's an important thing to make sure you're doing as much as you can, and also monitoring for abnormalities along the way and addressing them with medications where appropriate, in addition to your healthy lifestyle. So how serious are heart palpitations? Well, palpitations are very, very common. More often than not, they're just a normal heartbeat or awareness of an extra beat. However, if you are having palpitations, which is awareness of the heart beating more quickly or irregularly than normal, just heightened awareness of the heartbeat, it's important to take that seriously and know what's going on. So an approach to someone with palpitations would be to get them to describe the palpitations to you, what's the nature, and particularly whether there are any associated features of concern while they're having the palpitations, such as lightheadedness, chest pain, or even loss of consciousness. And then to understand whether that person might have an underlying heart disease, because if you have an underlying heart disease, heart muscle damage, valve disease and so forth, the palpitations are more likely to represent a risky heart rhythm, therefore require more urgent attention. And obviously understanding what other conditions a patient has or might have will inform your approach to investigating and treating this patient. So you need to take a good history, and obviously the more information the patient can describe to you about the nature of the palpitation, the more information that we can get through examination, specialist testing around the state of health of the heart, and also the electrical cause of the palpitation. So is it just awareness of a normal rhythm just going harder and faster than normal, or is there some sort of electrical short circuit or abnormal focus of activity in the heart which we can pick up with an electrocardiogram? Then we have a better understanding of what the cause of the palpitations is, the risk associated with them, what the most effective treatments would be to make the patient more comfortable, and also to reduce their risk of developing potentially life-threatening problems. I'm Professor Julian Halcox, consultant cardiologist at Sancta Maria Hospital. Please come and see me if you feel that you could benefit from my help, and get in touch with the team here at Sancta Maria Hospital. Thanks.